Welcome to This Explainer. Today, we're taking a really important journey to demystify a condition called hepatic encephalopathy, or as we'll call it to keep things simple, HE. Now, if you or a loved one are dealing with cirrhosis, you've probably heard this term thrown around in the clinic, and frankly, it sounds super intimidating, right? But don't worry. Today, we're taking a highly detailed medical algorithm and translating it into a practical, empowering roadmap for patients and caregivers. You definitely don't need a medical degree for this. You just need to know what to look out for and what steps to take.
So, let's start with a really fundamental question. What actually happens when liver disease starts affecting the brain? I mean, they seem like two totally separate systems, right? Well, think of a healthy liver like your body's own high-performance filter. When someone has cirrhosis, which is severe scarring of the liver, that filter basically gets clogged up or just stops working altogether. Because of that, everyday toxins that your body naturally makes, like ammonia, well, they aren't getting flushed out. Instead, they build up in the bloodstream, travel right up to the brain, and cause the cognitive and physical issues we call HE. It sounds terrifying, I know, but as you'll see, there is a very clear, structured roadmap to manage and even prevent it.
Here is exactly how we're going to break it all down today. First, spotting early warning signs. Then, identifying the hidden triggers. Third, understanding the severity grades. After that, common and effective treatments. And finally, staying on track safely. Let's dive right in.
Section 1. Spotting early warning signs. You know, the clinical algorithm shows us that the early warning signs of HE don't actually look like a massive medical emergency right out of the gate. Actually, they often disguise themselves as everyday fatigue or just stress. You might notice a slightly altered mental status, like mild confusion or disorientation in your loved one. Maybe they just forget what day it is, or they seem unusually irritable. Honestly, these personality changes are a massive red flag. Another huge clue? Sleep disturbances. If a patient is suddenly wide awake all night and experiencing intense drowsiness or somnolence during the day, well, that's not just a poor night's sleep. That is literally the brain reacting to those built-up toxins.
Now, while you're keeping an eye out for those behavioral changes, doctors will be looking for physical cues too, and the most famous one is called asterexis. This is a specific physical sign of HE where a patient gets this involuntary flapping tremor. Usually, a doctor will ask the patient to hold their arms out straight and bend their wrists back, kind of like they're telling someone to stop. If they have HE, their hands will involuntarily flap downward and then snap back up. It's a really key physical indicator that immediately tells the physician, okay, we need to suspect hepatic encephalopathy.
Section 2. Identifying the hidden triggers.
It's actually fascinating how mundane these triggers can seem, right? When someone has a brain-related episode, we instantly tend to think of some massive neurological event. But in the world of HE, everyday issues are the usual suspects. Something like a simple urinary tract infection or pneumonia can absolutely trigger an HE episode. So can taking sedatives or dealing with fluid issues like simple dehydration. Even constipation or a gastrointestinal bleed can be the underlying culprit here. So the medical team's job isn't just to treat the brain fog. They really have to act like detectives and treat all the reversible causes that sparked the episode in the first place.
So the crucial step here is how doctors verify what's actually happening. When a patient comes in confused, they're going to check their blood levels, including plasma ammonia. And here's the thing. If a blood test shows normal plasma ammonia levels, doctors know right away that HE is highly unlikely. This basically forces the medical team to pivot and look for alternative causes for the confusion, maybe a stroke, drug intoxication, or low blood sugar, instead of just assuming it's the liver acting up again.
Section 3. Understanding the severity grades. Okay, so this grading scale tracks the progression of the condition, and it's absolutely vital for caregivers to understand because it dictates the entire treatment plan. We start down at grade 0, which has no obvious clinical signs. Then we step up to grade I, which is mild, maybe just a trivial lack of awareness or a little bit of irritability. Grade 2 is moderate, and this is where you see obvious lethargy, disorientation to time, and that flapping tremor we just talked about, asterexis. Then we escalate to grades 3 and 4. This is severe territory, guys. It ranges from deep somnolence to an actual coma. Patients at these higher grades are at a high risk of aspiration and require immediate ICU admission to protect their airway. To make this a bit easier to digest outside of a hospital setting, the medical field broadly divides HE into two main categories. First up is covert HE. Think of this as operating totally under the radar. There are zero clinical signs you can see with the naked eye. It is detected only on specialized psychometric testing. The second category is overt HE. This covers grades 1 through 4. Overt means exactly what it sounds like. Caregivers and family members can actively observe the symptoms happening right in front of them, whether that's mild confusion or severe lethargy.
Section 4. Common and effective treatments.
The medical management of HOE might seem super overwhelming at first glance, but honestly, it is profoundly reassuring. Your medical team isn't just throwing darts at a board and hoping for the best. They follow a highly structured, evidence-based algorithm. This treatment escalation pathway is specifically designed to match the treatment precisely to the patient's severity grade. It makes sure that every single patient gets exactly what they need, exactly when they need it, right from their very first episode all the way through to long-term care.
Now, for patients dealing with overt HE, you are going to become very familiar with a medication called Lactulose. And when taking Lactulose, the primary treatment goal is incredibly specific, highly actionable, and, yeah, honestly, a bit unglamorous. Your daily target is achieving exactly 2 to 3 soft bowel movements every single day. Why? Well, because Lactulose works by drawing that toxic ammonia out of the blood and pulling it straight into the colon so it can be physically expelled from the body. Hitting that 2 to 3 target means those dangerous toxins are actively being flushed out before they ever have a chance to reach the brain.
So, the core drug regimen prescribed by the algorithm almost always kicks off with Lactulose, taken orally. Initially, right in the middle of an episode, it might be taken every 1 to 2 hours until those bowel movements actually begin, and then the dose is adjusted, or titrated in medical terms, to maintain that specific daily target. But what happens if the HE just keeps coming back? Well, if a patient suffers 2 or more episodes within a 6-month window, the algorithm tells doctors to escalate things. They'll add a second medication, an antibiotic called Rifaximin, taken twice daily right alongside the Lactulose, and they'll continue both of them indefinitely to keep that brain clear.
Section 5. Staying on track safely.
The clinical roadmap also includes a really specific warning section about critical pitfalls to avoid. It explicitly reminds medical professionals and, by extension, us as caregivers, of what absolutely not to do. Do not diagnose HE without totally excluding those alternative causes we mentioned earlier. Do not delay starting Lactulose. You want to start clearing those toxins immediately. Do not undertreat recurrent episodes. If it happens twice in 6 months, you've got to add that Rifaximin. And perhaps most importantly, do not forget to address the underlying liver disease itself. Remember, HE is the symptom, but the liver is the source.
Long-term follow-up means becoming incredibly vigilant about everyday routines. And honestly, this is where the power shifts right back to the patient and the caregiver. It means daily monitoring of mental status and, yes, strictly tracking those daily bowel movements. It means making sure medications are taken exactly as prescribed, no skipping. But it also expands to more holistic care, managing proper nutrition to prevent muscle wasting or sarcopenia, keeping totally up to date with all vaccinations to prevent those trigger infections, and regularly evaluating if a liver transplant might be the ultimate appropriate step. Wow, okay, we have covered a lot of ground today, from spotting those very first signs of confusion to unpacking the rigorous algorithms your doctors use to treat HE. But if there's one massive takeaway from this explainer, it's that this condition is manageable when you're proactive. Since we now know for sure that everyday triggers, like a simple UTI, a bit of dehydration, or constipation, can spark a severe cognitive episode, I want to leave you with this question to ponder. Are you equipped and ready to spot these triggers early and act on them before the next episode even has a chance to start? Thanks so much for joining me on this explainer, and stay empowered out there.